Real quickly, our midnight census is 454. We have now tested 15,993 patients at Bryan with 1,921 positive results, so right around 12% or so of those are coming back positive, holding steady. And we have pending results of 241. Number keeps coming down. With one of the advanced questions, there's some information on testing, so I'll give a little bit more detail on the pending test and some positive news there. In our hospital, we have 9 patients that are COVID positive. 8 are from Lancaster County, 1 from outside of Lancaster County. We do have 1 other patient in-house, certainly exhibiting symptoms, but is pending a result, so that means 10 positive or pending in-house, 9 from Lancaster County, 1 from out. None of them are in the ICU, and none of them are vented. All but 1 of them are in general care right now. So with that, I'm going to turn it over to Dr. Russell, and then we'll be back up for the pre-supplied questions and any questions you might have. All right, Dr. Russell, it's all yours.
Thank you, Bob, for that very generous introduction. I thought today it might be helpful if I shared some ideas and insight into some of the questions and challenges that I face with my patients every day in my practice when it comes to masking and COVID challenges. I sort of speak from the 3 M's, and I'll go through each of those, but usually we start with modeling, masking, and then myth busting. Those are the real priorities for us at this time. When I think of modeling, it's very important for children to see their parents, community leaders, role models complying with the masking policy, because if we do it, they're going to be more likely to follow those leads. And we know how challenging that is with younger children especially, but also the adolescents can be challenging as well. So when it comes to the mask, we have to get creative about that. You know, it's very appropriate to try different flavors of masks, different materials. Those children that have a lot of tactile sensitivities do a lot better with cloth or something besides those paper masks that stick to the back of your ears. It also helps to use some devices that help with the positioning of the mask on the face and the comfort level, whether you use hair dye ties or even use little extenders at the back. You have to get really creative and try some different things. And it's really important to find some of those masks that are sort of child-friendly. Maybe it's their favorite superhero. I think what's happened, and I've certainly seen that, is when we turn the ingenuity of the American system open, a lot of creative things come out of that. And so everyone has been coming into my office with some really unique and different masks that seem to be very effective and really help with the compliance with the children. And then the next thing is really to bust the myths. I think it's really important to let your children know, and especially even your adolescents, talk to them honestly about how masking really does make a difference. There's no question. We know that masking, universally used, does decrease the spread of the virus. It's one of the simplest, least expensive things we can do. And with school opening up here in the next few weeks, it's very important that we work on practicing compliance with masking. So at this time, if you really want to help your children tolerate and comply with use of the mask, practice doing that now. Start out with maybe a short amount of time. Manipulate the position. Get them very comfortable. Make sure the material that it's made of is comfortable for them. Let them play with their mask on. And then again, encourage, support, lots of positive praise when they comply. A little bit of groundwork laid now will be very helpful with the first day of school. And then the last thing with myth busting, we also want to make sure that it's relevant, true, simple, speak to the language of your child's level, It's not to scare them, but to just answer questions about viruses and how they enter the nose and the mouth. And by covering that area, you can prevent the spread of the virus. Just a couple things, too, that have come up recently I'd like to give a shout out, and that is we do get some questions about what happens when an exposure is positive and we're tested and our test is negative. Do we still have to quarantine or isolate? Yes, even though you had a negative COVID test and you were exposed to a positive case, you still should quarantine for 2 weeks, partially because the test isn't 100% accurate. And the other thing that would really help is when we do have, and I'm speaking especially to adolescents who tend to socialize together, a positive case, it's very important that you help our tracers at the health department find and expose, not just expose, but at least work with us to help find those others that were exposed at the time with you so that we can test them appropriately and really help prevent spread of the virus as well.
We were addressing this, late June, early July when things were ticking up just a smidge, and we said based on what we knew and had learned in the first couple of months, we expected an uptick on the week of July 13th or July 20th. At the time of those questions, we were sitting at really steady at about 4 hospitalizations, and this past week or the week of July 13th, it more than doubled, and we're 10, 11-ish right now. And I also know that on the week of July 20th, which we're now in, last week you've seen from the great coverage again that we had the highest positive results in the county last week. So we do expect the hospitalizations to continue to trail and creep up, not only this week but over the next couple of weeks. All told, in the last 14 days, from the latest information from Lincoln-Lancaster County Health Department today, there were 596 positive tests in the last 14 days. To put that in perspective, that is 25% of all positives we've had, yet it only represents about 10% of the days since we've been uncovering positives in the community. So just stay vigilant, everyone. I pulled some stuff that we shared a couple of weeks ago, and it was recent as of July 8th. We're going to have to grab more. I just didn't have time to get that at the time of the advanced question. However, what we shared on July 8th is about 12% of our cases are under the age of 19. Conversely, only about 4.5%, 5% are over the age of 70. So I think at that age or that time we said we were skewing just a tad younger than maybe some of the national statistics. But again, about 12% of those in our area have been under the age of 19.
We're finding that the younger children are often asymptomatic carriers, but usually don't get as severe a disease. The concern, of course, is who is living in their household, who they're exposed to. Are there high-risk family members that, should they contact COVID, would have a significant health exacerbation, perhaps be hospitalized and ventilated? I get questions sometimes about what about our play groups. I think someone here, Nathan, has asked a very good question, if you don't mind me bringing you in on this. But, what about my younger children? We're trying to continue to help our children socialize, which is very important, of course, with normal development. What can you do to have play dates or things where you can at least get together with some children? And I think there's a few things you should take into consideration. Number one is who is in the household should your child pick up COVID at a play date, and is there a high-risk person in that home? And in that situation, you want to be very careful about outside exposures. Obviously, and you've probably heard being outside is better than being inside. The smaller the room, the more concentrated, and the chance of transmission. Also, the number of children and adults that are at the play date, the higher the number, the higher the risk. So minimize those numbers. And then, of course, if anyone has symptoms, fever, or any sickness or exposures, those children should not participate. So if you trust the folks that you're planning the play date with, and everyone is in a healthy situation, there's no high-risk adults or family members, and you keep the numbers small, certainly considering those things as appropriate. As far as the multi-system inflammatory syndrome that we've all heard about, or what's called MISC in children, that is a very severe, concerning response to COVID infection in children and adolescents. Fortunately, so far it's been very rare, but in that situation, what we've been on the lookout is if a persistent fever for 3 days or longer, particularly in a child or adolescent that's acting a bit sicker than the normal virus or cold might cause, should be evaluated by a physician right away, because it could be caught early. We have screening protocols in place that have been developed specifically to rule out the inflammatory syndrome, which, if caught early, is very treatable, and complications can be reversed very rapidly if you catch it early. So that would be one caveat that I would keep in mind. And again, not to be afraid, but be aware.
Just as far as test supplies, hot off the presses, our lab director, Christy, has been here before presenting. She sends out something daily, and as you recall, we have kind of 3 different tests. The top of the line is the Cepheid test, and we are in good shape with those right now. We have 94 on hand, and with another 120 that are expected this week. Those are the ones that have like an hour to 2 hour time frame, used for inpatient and stat orders only. In the next category, the Aries test, we had 120 arrive yesterday, so we have 926 on hand. Those are, kind of a 2 to 3 hour turnaround, and they are for Bryan Health inpatients and routine orders. And then the ones that are done at our drive-through and our walk-up clinics that are sent to LabCorp, there's an adequate supply at this point. So we're in good shape. However, there are some different systems in this region of the country that are no longer accepting orders for pre-op testing at all. So I don't know how that'll impact us, but it's going to limit the ability, as current supplies stand, of doing something large-scale sweeping for a school system or a college. And in fact, some of the small colleges for athletic participation have approached us, and frankly, we had to pass on that because we need to maintain the supplies here, and that would burn through it if a lot of the small regional colleges were doing it just for athletes.
First, the LPS guidelines will be coming out later this afternoon, so obviously those are going to be very helpful as far as how we address this when school starts. But I still stand by my recommendation that if you are exposed to somebody that's positive, even though you tested negative, you still should quarantine for 2 weeks. Let me just say a little bit about the vaccine. There has been some early clinical trial. You may have heard a phase 2 study on a very small population that did show an immune response. Also, that the side effects, although were a little bit annoying, weren't dangerous on a small number. But of course, to really prove the safety of a vaccine, you have to have a much larger study. And so when it comes to recommending something, we're going to need to look at the phase 3 studies, of course, and see if there's any adverse reactions that would contraindicate use of the vaccine. So until I see those, I wouldn't make any recommendations to my patients or family. Just another note on vaccines. The other thing we don't know yet is, even though the vaccine that was studied and a few others that are in process does trigger an immune response, there's still questions about what level of an immune response is protective. So yes, the vaccine created antibodies that protect you, but we don't know how high that antibody titer needs to be to protect someone from getting the virus when exposed. And also, we don't know how long those antibodies will last, whether it's going to be a lifelong immunity, like perhaps with your chickenpox vaccine, or if it's going to be temporary, like some of the influenza viruses our vaccines are temporary and you have to be boosted routinely. So there's still a lot of questions out on that. So my answer to my patients is we still have to wait a little bit longer before we can make any serious decisions about what I'm going to recommend as far as the vaccine. Hopefully something will come up. We have some circumstantial evidence that children tend to not be as ill, but particularly shed the virus. There has not been any studies that definitively have shown that certain populations shed virus less than other populations, whether it's age group or ethnicity. So that's a very difficult question to answer until we've had this around for longer. We have time to do those studies and actually look at viral shedding. So I like the thought that maybe children don't shed as much, so it's going to be a lot safer for them to go to school. But to be honest, we can't really say that right now. We just have to presume that everybody sheds that's exposed or is positive.